bodybuilding, drugs versus diet. Interview today with an IFBB Pro dietitian, Chris Tuttle. Thank you, Chris, for coming on the show today.
Thank you.
Great to see you. I've known Chris for many, many years. We both are from Connecticut.
Many years.
So here's what we're going to do today. We're going to get right to the point. We all know that professional bodybuilders, despite having great genetics, training hard with great diets and determination, they all use steroids, not to mention other drugs, which we're going to talk about today. We agree with that, right?
Yeah. I mean, there definitely are some IFBB pros that, won Team Universe and are natural. They're not on the Olympia stage, but I mean, it is achievable for a very, very, very tiny, minute percent of people to become an IFBB Pro without using them. They just don't get very far as a professional.
But not to win the Olympia.
Oh, no.
Okay. So let's just get right down to business. Let's ask the question to this professional man who's a professional bodybuilder, and also, more importantly to me, I respect him, he's a dietitian, and he's a good one. So, the drugs, let's talk about it. The drugs from pro bodybuilding, right down to the amateur. All the drugs, let's go.
You mean as far as what they use, or what people think they use?
What drugs are used to create a professional top 20 bodybuilders in the world?
It's a good question. I mean, a lot of people will use a variety of different things and compounds, and people suspect and will say this is what their pros work or that pro uses, but really a lot of lines between the genetic amateurs and pros is really mainly genetics that separates how far somebody can go using particular compounds than others, where a lot of the assumption comes from they just use double, they have a secret formula, etc. So a lot of times people's persona of that is just different. Somebody being further along in much better symmetry, physique-wise, is not necessarily a drug thing. Obviously there's drugs there, but it's not like you just double more and you get double the effect.
Let me ask this. Let me focus this. Drugs for bulking. Anabolic steroids, we're going to talk about insulin today, growth hormones, and peptides. You know about all this stuff.
I know nothing about peptides.
Okay, anabolic steroids. Well, we'll leave that for the other interviews, for the other guys. Okay, I see the medical side of this. I don't know what drugs are particularly being used, how they're used, the mechanisms from the side of what's actually used. Of course, I see it in my history. I take my histories, and men come to me usually after using steroids for years, and they want to be recovered and they want help, or they have a medical issue. So there's no better way for me to ask someone who's in the industry. We're not saying you're using steroids. You're in the industry.
Oh, what people do?
Let's talk about the bulking. I want to talk about 2 cycles. Bulking cycle steroids, and I want to hear about what's used for cutting cycle.
Well, we'll talk about amateurs first. A lot of the information and stuff that people are gaining, unfortunately, is from forums. Forums are usually full of, in my opinion, people who really have no business giving information out, falsifying information, posting pro cycles on there, where the general gym goer, young individual will see that and try to duplicate that same cycle.
But that's what we have, though.
Right, thinking that's
what we
we're supposed to be doing. So, I mean, generally an off-season cycle is usually things like, things in the forums are stated like testosterone, deca, D-ball.
How much testosterone?
I mean, some forums, people say up to 1,500 milligrams a week.
Wow. People really take that.
Yeah.
What's the highest dose of testosterone you legitimately have heard a bodybuilder use? Per week.
He was actually not even a competitive bodybuilder, and he's actually dead. I actually did know him personally, and he was doing a bottle a week. A bottle a week.
How much is that?
So 250 milligrams times 10 cc's. He was doing, what is that, 2,000 milligrams a week?
So 2 grams a week, that's not much. That's not, I mean, guys, that's not much, but guys do 3 grams a week. So,
yeah, I mean,
it's
this
crazy.
is the thing. There's so much hearsay, and nobody really like sits there and will, if somebody's huge and somebody goes, "This is what I'm taking," and that person goes, "You're too big for that," you're lying. Versus then you get somebody who's small comes in and they go, "I'm taking this much," and someone goes, "Man, your stuff must be fake because you're not huge." So there's a lot of that. So nobody really like is sitting there dead set in stone like this is what they're taking, this is what they're not.
So testosterone.
It's a wide variety. So wide array.
But let's just for the audience, for my supporters in the world, they want to know, and I want this to be educational, and I don't want people to do this unless you understand that you're going to potentially have health consequences.
Yeah.
Okay, this is educational. So, but what do they? So, okay, testosterone esters. This is bulking cycle. I would say that let's just focus on the top of the top pros that are genetically gifted, they're training hard, and they're game on. What do these guys use?
Honestly, I can't vouch for what pros use specifically.
What do you think?
I honestly think, from what I understand, and obviously I'm not, pointing anybody out, some of them take a very small amount in retrospect to what they look like. And that's genetics. I make that analogy sometimes, like if you buy a Porsche 911 Turbo, you don't need to do much to it to make it fast.
Correct. It's already a turbo.
Right. If you get a Honda Civic or Volkswagen Beetle,
interesting,
you're going to do $100,000 of modifications to that.
Why we're doing this.
$100,000 of mods to try to make that Volkswagen Beetle faster. And what do you do when you put that much mods into a car?
It breaks.
It dies.
Okay.
Fast.
So how much? Sorry, guys.
It's hard to. I don't want to say this and then have it be, not exactly, but I would say on average, you could probably say people use generally 750 to 1,000 mg of testosterone a week.
Thank you. Other drugs, other injectable steroids.
You could say that people generally maybe use DECA between 300 and 400 milligrams a week.
Test and DECA, that's the combination?
Yeah.
Really?
For off season.
Okay.
Yeah.
Okay.
People use Test,
still,
DECA.
40 years now, still using the same.
Yeah.
Okay.
Well, now a lot of people, like, I've been kind of more out of the loop to everything that's new that keeps happening.
That's
all
a good
these
thing.
New things that keep coming out.
I'm glad you're out of the loop.
Right, but like all these new things coming about and people trying to go more and more aggressive because there's a general persona a lot in the industry that people are doing more dangerous things today than they were 10 years ago, than they were 10 years ago, than they were 10 years before that.
That's true.
It's getting more and more advanced.
It's true.
And that's a scary thing because I feel like today a lot more people are out of touch with their own self-responsibility. And they kind of push things to the wayside and risks to the wayside.
And we're going to talk about that in the end. So Test, DECA, what other bulking steroids?
EQ,
equipoise,
oral steroid anabolics such as Dianabol, Anadrol.
Old-fashioned stuff. So the top guys, as far as you know, are still using the drugs from 40, 50 years ago?
Yeah, like I said, I don't know them personally to be able to, like, those are generally the most common things people are using.
Now,
and I'm even aware of that some people actually will legitimately come off everything for a quite good period of time.
Yeah, right.
Or they even go down to just their regular normal testosterone dose, a low hormone replacement dose for a good portion of the year.
So blasting and cruising.
Yeah, but I would say more or less the appropriate range of testosterone levels for a portion of the year.
So TRT. Kind of the cruise is a TRT cruise.
Right. A blast can be considered, people say, 500 milligrams a week.
That's
a cycle.
That's correct.
Right.
Good point. Okay, cutting drugs. Now we are, how many would you say, when does cutting start before a professional bodybuilding show?
Well, cutting general preparation for a show with diet and cardio really depends on how overweight the person is and how much fat they have to lose, of course. It could be 12, could be 8 weeks, which is very few for some people. Could be 12 weeks, could be 14, 16, or 18 weeks. Generally, people don't usually start those cutting compounds until 12 weeks out or 8 weeks out.
Okay, tell us how you transition from the bulking phase with those sloppy, watery esters and the D-balls and anadrols, if you will. How do they phase into the cutting phase with those drugs?
There's so many, I've read so many different things. Generally, people do is 12 weeks out, but this could change between 6 and 12 weeks out. And obviously, depending on how good they look, will determine how much and how little and when and so forth. But usually it's still your testosterones. They'll still use, they might increase aromatase inhibitor to block some of the estrogen conversion.
Wow.
They'll might add in masteron and ethate or masteron propionate.
Wow.
Trenethate or trenacetate.
Trends coming into play.
Yeah. And then, towards the end, they might throw in an oral like stanzanol. They use clenbuterol for cutting. They might add a thyroid hormone.
Wow. Wow.
And usually those are kind of juggled, adjusted, through the preparation based on how the individual's progressing or and so forth. But that's the general line of
what do you know about growth hormone, and what do you know about
I don't know too much.
IGF?
I don't know anything about IGF.
Okay.
I know a little bit about growth hormone.
And these bellies, it looks like.
Well, there's a theory on that. And I don't know. I'm not a doctor. And many people, no doctors are prescribing 10 IUs of growth hormone a day. So what's causing the bellies? My theory is honestly like mass quantities of food, weak core musculature, stabilization on your core. And to be honest, like you can't be 300 pounds with a small waist. It doesn't happen. Just like you're not going to see a professional strongman or a powerlifter who has at the pinnacle of lifting 1,000 pounds and have 18-inch waist.
He needs that weight. He
needs that
support,
core stability. So I think some of it's that. A lot of times I just think sometimes that people are just force feeding themselves and eating above and beyond what normally their body.
But that's what they're doing, and then I've done interviews and I've talked to other experts on this in the industry, and it's no question it's a polypharmacy of growth hormone and insulin and the calories. Correct.
Yeah.
So and it can even be very watery. They can have problems holding too much water. So then let's talk about diuretics. What do you know about these? It's so dangerous. So dangerous. Diuretics?
Diuretics are, I would say, it's real scary because your people are trying to purchase diuretics in the black market. So like
it's all from the black market.
But
everything's.
But what's scary about the diuretic situation is people will exchange diuretics by hands from people to people.
Wow.
And they will just trust what they say. So
wow.
For example, I've heard this before where somebody goes, "Hey, I need to get 25 milligram hydrochlorothiazide. I need 2." The guy goes, here's 2 of them. Okay, the guy takes 2 of them. He goes, "All right, great, got it." And says to his coach, "Hey, I got these 2 diuretics." And that coach, thank God, is smart and goes, "Well, can you send me a picture of the pills?" So he looks them up. They're Lasix.
Wow.
So that's real scary because now you don't know what the dose was, and that person didn't have the intuition to know because you're just exchanging pills. You're not getting out of a bottle. You're not getting a blister pack.
How many patients, or how many of these competitors you think on the pro level use diuretics at all in the end?
I personally feel that people are getting away from diuretics currently.
Wow.
Good. I don't think it's as widespread as it once was. I could be totally wrong. But, generally diuretics is it can make you flat. And once you inhibit the kidney from reabsorbing sodium, you can't really...
It can make you fall, get dizzy. Because
you can't really fix it. So like you take a pill to get 5% drier, then you lose 15% fullness, then you look worse. But I think a lot of people are using tinier doses.
Wow.
Like 6.25 milligrams of hydrochlorothiazide. Like once or twice, versus doing like 25 milligrams like every 2 hours or something, which I read that some people used to do back in the 90s.
Wow.
And then people are getting away from aldactone.
Wow.
Because of the higher potassium levels, and if you flatten yourself out on aldactone, you really can't fix it.
It's amazing to me. This is true bro science, and you're kind of a broologist because you're a
broologist.
You have to be. The guys that are out there in the world that know this are not functioning off of doctor's information because it doesn't exist. That's why I'm in the world to figure this out and to try to do the research and try to give a loving, caring,
and help people
technique and a perspective of education so we could take it and study it, because there's millions and millions of people and more coming that are using all these drugs, not just steroids, but growth peptides, growth factors, SARMs, and real medical agents, including thyroid preparations, insulins, diuretics, and just polypharmacy, metformin, And we don't need to go into all this today. So,
and one thing I want to add to what you just said is, and like I think this is the thing that's difficult for a lot of people is, a lot of these people who are recommending these things, writing these things, discussing what people say or do. Some of it's hearsay, but one thing that people I think need to understand is there's a difference between being a professional in that field and there's a difference between having personal experience in that field. And as we know, in medicine and science, anecdotal evidence or personal experience doesn't trump anything when it comes to being professionally knowledgeable about
evidence-based.
Right.
Yeah.
So like a lot of this stuff people are recommending, it's like this is just like rolling the dice.
But hold on, but it's 100% only anecdotal.
Right.
Because and I'll add to that, in the medical world, we rely on evidence-based data. Studies.
Right.
Studies. We've been trained to be very regimented and to rely on studies. When you're being trained as a physician by the older attendings, you'll be in a hospital training and you'll see patients, and then the doctors will every time classically tell us what this is, tell us the background, give us a pathophysiology, and give us the best articles recently regarding this disease and how you're treating them. Now, that's evidence-based medicine. That's what I'm doing for anabolic steroids. That's my plan as a testosteronologist. So when it comes to, this is 100% only anecdotal, but it's been anecdotal for 50 years.
Yeah.
So the drugs, okay, we covered the bulking, we covered the cutting. You don't know about the growth factors. Let's talk about PCT.
I know a little bit, but it's like not enough to comment on.
It's okay.
You know?
It's you know about steroids, and I want to hear about that. You know what's used bulking and cutting, and I'm learning a lot on this. So let's talk about PCT now. Post-psychotherapy. What do you know about that? And how's that moved from last 10, 20 years?
Well, generally people today do not really do PCT anymore.
Wow. Hold on. That's blasting and cruising then, right?
Yeah. And like everybody has their own definition of what blasting is. And this is always something that people just assume. So this always happens. Somebody looks greater and better than 10 other people. They must be doing something more or staying on longer or doing this or doing that.
Wow.
So therefore I need to do that.
Wow.
And then you ask that person, well, where did you hear that from? Well, I didn't hear from anybody. I'm just assuming because he can't look like that or do that. So I need to do that.
The picture sells.
But it's mind-boggling. So a lot of people like are afraid to feel that low testosterone effect. So 10 years ago, people were always cycling on and off.
10 years ago.
Yeah, I mean.
In your opinion.
Yeah, people like that was like the known thing to do. Like you have to be careful what you're doing. Your people are using a drug and they realize that. And I think personal self-responsibility was greater 10 years ago.
10 years ago and before.
Yeah, it seems that way. And and from what I've seen in the gyms and things like that.
It's true. I agree with that.
And then now
from the 90s, my era,
right,
80s and 90s, 100% guys did come off.
Right, and then today now people just will stay on what they refer to as like a blasting thing.
Wow.
Blasting thing could be 100 milligrams testosterone a week to 500 milligrams testosterone
cruising.
a week. Yeah, I mean, yeah, right, cruising. And then I always say I think to myself, I'm like, Jesus, if this person is defining a cruising on 500 milligrams, they don't even want to know.
Well, that seems like the average, and I'm just here to give the data. The average cruise now is, hey doc, I'm on the cruise, I'm on the TRT, they call it TRT or HRT, and I'm on just physiologic. Well, how much are you on? 400 to 600. It is interesting. That's what my notes show, and that's part of my data. The average guy. Some guys will say, doc, it's 200, and that's closer to, to what's going to be.
From what I understand, 200 milligrams per week could still bring somebody too high.
Correct.
Or it might bring them in range. You don't know. Unless you're monitored.
That's the genetic difference. And then how you deliver it. Is it a bolus once a week, or is it broken down to 100 intermuscular injections every 3.5 or 4 or 5 days? That's the trick. That's what I do as an expert once they're diagnosed. And TRT is not giving a bolus every 2 weeks to a month, which unfortunately a lot of physicians think.
A month, once a month.
And it goes up and down. Now again, we're not here to disparage physicians. They just don't know. These are excellent physicians. They're not testosteronologists. They're not involved. They don't know. And some do. There's a lot of doctors that certainly know. It's very easy to understand. You don't want to have it peak and trough. You want to give consistent doses, so you break down the frequency that it's going to, based on the man's genetics, metabolism, his other medical issues, how it's going to be given to him in a steady state. Not for this so much, but for his brain and his sex drive, and that's what in mood and libido.
Yeah.
So post-cycle therapy, what are the drugs?
People use a variety of things. I've heard a variety of different things. Okay, so if you put everything on the table, you have tamoxifen, referred to as Nolvadex. You have anastrozole, which is Arimidex. You have HCG. I've heard people use Proviron.
Interesting.
And then some people just throw in more steroids thinking during PCT.
Amazing.
like a 5 or 10 milligrams of D-ball or 10 milligrams of Axandrolone,
for
during the PCT.
How's that going to?
I don't know.
Interesting. I've never heard that. That's cool. I mean, I've heard that, but is that real? I mean, is that?
I don't know.
Proviron's an interesting drug.
I'd say I've looked at forums before to see what people are like. Somebody from the gym was saying some things that didn't make any sense, and I'm like, I don't know how anybody can be so stupid. Where they really make that up? They just read that from somewhere. So they sent me a link to this forum. I looked at the forum and seeing what all these people are writing, and they're stating it as fact, as like this is what people are. This is what so and so's doing. I've seen them do it.
These are forums.
It's just crazy poor information.
So post-cycle therapy, and the doctors, including myself, we're getting involved with that now to know how to really have a man come off to maintain his wellness. So I'm going to conclude on that today. I don't want to keep these videos going on too long, but we're going to have a series, I think, with Chris, if he'll come on, so I could keep myself tied to really what's going on more or less in the world of the bodybuilding and the fitness world, because they're utilizing drugs.
Yeah, and the nutrition keeps changing with it too,
And you know what? Part 2, we're going to do the diet.
Yep.
Thank you so much, Chris.
Thank you.
Thank you so much. Dr. Thomas O'Connor here. I'm glad you made it to the end of the video. If you liked it, hit the like button and please subscribe to our channel. And I look forward to bringing you more cool and interesting videos just like this in the future. Stay strong and healthy.